afternoon, everyone. Thank you for joining us today. On behalf of Myanmar, welcome to our webinar, Bridging Knowledge, Practical Perspective in Breast Pathology. I am Dr. Bini Puinsan from Myanmar, and it is a pleasure to be your host. It's my great honor to introduce our speaker, Assistant Professor Wanwisa Himakhun, MD. And Dr. Wanwisa is a highly respected pathologist with a strong academic and international experience. She earned her medical degree from Thammasat University, completed her residency in anatomical pathology in Ramadiponi Hospital, and pursued advanced training in cytopathology and breast pathology at UCLA, USA. She is currently an assistant professor at Thammasat University, specialized in cytology and breast pathology. And we are truly delighted to have her share her expertise with us today. Before we begin, just a quick note about the questions. Please feel free to submit your questions at any time using the Q&A box. For the phone user, the Q&A box is on the top toolbar, and for the PC user, the Q&A box is on the bottom toolbar. For our facilitator, Dr. Su will collect your questions and guide them to Dr. Wanwisa during the Q&A section. All microphones will remain muted, and today's session will be being recorded. And now, without further delay, please join me in welcoming Assistant Professor Dr. Wanwisa, MD.
Okay, so today it's my pleasure to be invited to speak about the bridging knowledge about practice and perspective in breast pathology. So today my topic will be include about some interesting cases that may be useful for you guys for your practice. And I have some immunohistochemistry discuss and some molecular clues for each case. And at the end of each case, we may have some quick question for you guys for the guess about what it should be. So please feel free to join our poll by the end of each case. So let me start. For this lecture, for the bridging knowledge of breast pathology, what the objective of this lecture is to understand the diagnosis gray zone between spindle cell lesion and epithelial tumor, and we can apply morphology pattern and recognize some of the pattern and guide to the deeper ancillary tests, and also integrate some immunoprofile and some molecular tests that can help on classification of each tumor. So shall we start for the first one? Let's say. So this is the case of female 46-year-old. She present with the left breast mass for 4 months. And she also did have a history of cerebral infarction, atrial fibrillation, hypertension, but her family did not have a history of breast cancer. On physical examination, the surgeon, she said the patient have the left breast mass for 5 centimeters. That's rather well circumscribed, but the skin above the mass does not show any change, and her axillary lymph node is not palpable. For imaging, this case was around 2 or 3 years ago. The imaging findings, they have the left breast mass that's called BIRATS 4C, and the size is 5 centimeters. It looks lobulated and hypoechoic in the mid part of the left breast. And before she come to our hospital, she went to the other hospital near her home, and they performed corneal biopsy from out lab, and that was called spindle cell neoplasm. And this is what we have from the previous biopsy. On 20X, you may appreciate the area that looks doesn't look like breast anymore, right? This one is look chondroid differentiation. And the matrix look kind of blue and look myxoid on here. And the other area is show like pleomorphic spindle cells around here. So at first diagnostic, it was called malignant spindle cell neoplasm with chondroid material. And we didn't see any definite epithelial component in the biopsy. The mitotic count was 10 out of 10 high power fields, and the spindle that show moderate to mildly nuclear typia. And for the comment, at that time, we didn't have much on epithelial, right? So I leave the comment for the biopsy that the differential diagnosis of this case could be tumor with sarcomatous component, maybe including malignant phylloides tumor versus metaplastic carcinoma, or maybe sarcomatous itself. So if we talk about malignant phylloides tumor, let's see. Okay, when we talk about phylloides tumor, the phylloides is meaning to the leaf like this. So in benign phylloides tumor, we should see the architecture that look like leaf like this. But for malignant phylloides tumor, we see the stroma increasing with maybe less of epithelial component, with necrosis, with hemorrhage, with infiltrative border. And if we come to core needle biopsy, when the surgeon or physician put the core inside the biopsy inside the mass, you may see only stromal component without epithelium findings. So that's why I put the comment for complete exercise for evaluate epithelium component should be helpful for evaluate in this case. And I said to my surgeon at that time, okay, please give me more and more of tumor. Maybe we can see something else. Then the patient go through mastectomy with sentinel lymph node biopsy. And for the sentinel lymph node biopsy, it shows negative for malignancy in 2 lymph nodes. And this is the breast mass from mastectomy. We see the large mass here with hemorrhage, necrosis. And it seems that the tumor is here, so whitish tumor, and then I see the epithelial-like component here. And my resident, she took the sampling of the mass, I think around 20 or 30 blocks, and it show high-grade malignancy with epithelial and spindle, and some myxoid with chondroid, osteoid, multinucleated giant cell with massive hemorrhage and necrosis area. Well, still didn't see any epithelium component. And the tumor size is 9 centimeter, mitosis count 10 out of 10, and the tumor border show infiltrative on the border of all sides, and the resection margin still uninvolved. And after that, I think maybe we are encounter with malignant phylloides without any epithelial or sarcoma of primary breast. At that time, 3 years ago, I have never signed out primary sarcoma of the breast. So I think it's time for sending for consultation. So I send the case to senior breast pathologist. What we see from the last, the mastectomy specimen is this one, sarcomatous component, like pleomorphic spindle cells and mitosis. And if we compare to benign breast tissue, it's totally different, right? And also see some multinucleated giant cells formation around the pleomorphic spindle cells. And also see hemorrhage and tumor necrosis in the central portion of the tumor. And after waiting for a few days, my senior breast pathologist, he sent me the consultation note. Like, okay, microscopically, the tumor is composed of as mixture of predominant pleomorphic spindle cell, mesenchymal component, mostly chondroid and osseous differentiation. And he also see that no leaf-like papillae or benign slit-like gland within the mass. On addition, he didn't see obvious malignant epithelial component. And he said, based on the histomorphology, the differential diagnosis may include metaplastic carcinoma with heterologous mesenchymal differentiation, and also sarcoma, whether primary or metastasis to the breast. And he add a comment like, please give him more. Like additional tissue sampling is required. Wow, I already took 30. Huh? And he said, ISC for high molecular weight cytokeratin and P63 may be helpful for distinguish between metaplastic carcinoma and sarcoma. And for differential diagnosis between metaplastic carcinoma and malignant phylloides tumor, we can look for the epithelial components. If we see malignant epithelial component, we think about metaplastic carcinoma. And in spindle cell component of metaplastic carcinoma, it will be positive for high molecular weight cytokeratin as well as P63. And sometimes you may see squamous differentiation in metaplastic carcinoma. In contrast, in malignant phylloides tumor, the components are negative for high molecular weight cytokeratin and also P63. And for CD34 and BCL2 may express in sarcomatous component of malignant phylloides tumor. So at first, I think, okay, we can go back again and try sampling more to see if we have something like epithelials or just the similar things for the first time. So 2 years ago, I took like 60 more blocks for this case. That include entirely portion of the tumor. So I think we should have something for this time. So this is what we have from 1 out of additional 60 slides. So let's say this is the poll. Let me launch the poll. One. Okay, I can start the poll now. So what do you think about this one? Wow. So I let 10 more seconds. Okay, it seems everybody like 40 something. Okay, we should stop the poll. And Wow, interesting. Like most of you think about malignant phyllodes tumor, like 55%, and primary sarcoma for 20%, metaplastic carcinoma for 25%. Okay, let's go. And this is what I mentioned before. I got from one out of the additional 60 sampling. Does this look like leaf? Yeah, to me, it's a little bit look like leaf-like architecture here with some pleomorphic tumor around here as well. So when we look closer on the areas that look leaf-like, we see some benign looking epithelium here. And it's epithelial component. And we use the stain for CK here and also positive for cytokeratin here. And for other immunohistochemistry, in the stromal component of this slide, they are positive for CD34 focally here, and the stromal component negative for CK56, P63, and cytokeratin. So the final diagnosis of this one, I call this high-grade malignant, suggestive of malignant phyllodes tumor, and the tumor size is 9.7 centimeter. Mitosis figure is 10 out of 10. The border is infiltrative and also show malignant heterologous component. And we see stromal overgrowth and markedly nuclear atypia with necrosis in the central portion of the tumor. All resection margin are uninvolved by the tumor. And if we look on the AJCC 8 edition, this is called for P pathologic T2 tumor without metastatic. Okay, that's the first case. And then we shall move to the second one. For this case, I have this case, I think 3 months ago. This is a case of female, 65 years old. She present with right breast mass for a month. For the history, she had DM hypertension without family history of breast cancer. For this case, the physical examination, we see the surgeon, she said the patient have right breast mass 8 centimeter with the skin edema and thickening in 1/3 of the entire breast area. Also suspicious for axillary lymphadenopathy for 1 centimeter on the right side. And interestingly, she also have a mass on the abdomen on the right side. It is 6 centimeter that was fixed to the abdominal wall. And she go through imaging findings. And for the breast, the radiologist said it's 7 centimeter mass and show lobulated hypoechoic on the right upper outer quadrant. And the axilla is 1 centimeter. And for abdomen, it show abdominal wall mass at the rectus cheese. So, and they cannot identify whether it's primary or metastasis of the tumor to the abdomen. This is the core needle biopsy. Actually, I have 2 core biopsy, one from the breast and the other from abdomen. But both biopsy it looks similar. So I took the breast for you guys. So this is the core biopsy from the right breast mass. You see this area, it show lots of blue cells here. And the other in the central area, there's some necrosis and hemorrhage, and also something look like bluing stroma here. In high power, you see this, like small bural cell here, infiltrate everywhere. At that time, I just wonder, oh, is this breast or something else? And in the area that look myxoid, we have some cells that look maybe like epithelial or chondroid or anything around here, a little bit here. And at that time, we did not have any immunohistochemistry for diagnosis. So I put the initial diagnosis as malignant round cell neoplasm and try thinking of many things, maybe primary or maybe metastasis or maybe something else. So the differential diagnosis may include polydifferentiated carcinoma of the breast, or maybe sarcomatous component of malignant phylloides like 2 years ago, or maybe metastatic round tumor to the breast. And I asked for additional immunohistochemistry. Oh, and let's see. For immunohistochemistry, we have A1, A3 that look negative on the blue round cell here. And at that time, since the tumor look blue round cell, I have to put the differential diagnosis of hematologic malignancy as well. So I put CD3 and CD20 on the biopsy, and it's shown negative for both immunohistochemistry. And I have S100 that look positive in the blue round cells. Then I put GATA3 for evaluate whether this is breast or something else, but it's not impressive. I mean, the positive nuclei look like equivocal to weak staining, and some area it look like it's negative. So to me, I put it like equivocal for GATA3, and for ERPR is also negative for the entire area, and for HER2 it's also negative. So for the immunohistochemistry result, we have negative for almost all of them, like negative A1, A3, negative CD3, CD20, and GATA3 show equivocal to negative. S100 only the one that positive in focal area. And I send it to soft tissue pathology to evaluate if she have any idea. Could it be primary sarcoma or something? And she put immunohistochemistry for soft tissue tumor, but it negative for SMA, Cal-Desmond, Desmin, CD 34, ERPR are negative, but the tumor show high KI index, almost 80 to 90%. So we agree to put the comment by the end of this report, like correlate to histology feature with immunohistochemistry study and the tumor location. The differential diagnosis at this time may include sarcomatous component of malignant phylloides, and we need epithelial component to diagnosis of malignant phylloides tumor, like 2 years ago cases, and maybe include primary sarcoma, that include myxoid chondrosarcoma, and high-grade round to epithelioid cell sarcoma. After we give the diagnosis, the patient was sent to the oncologist, and they start doxorubicin on June. But after like 1 or 2 months, she came for follow-up, and the breast is grow bigger. Now from 7 centimeter, it's turned to 10 centimeter, and the skin still look edema on the right side, and the mass on abdomen is grow a little bit like 8 centimeter and still fixed to the abdominal wall. My breast surgeon, she called me and she said, "Oh, it's grow bigger. Maybe the patient cannot go tolerate for the mass that's grow bigger in each month," and they decided to have an operation for right total mastectomy with sentinel lymph node biopsy and do right abdominal wall tumor removal. And here, what we have for abdominal wall, like 8 centimeter here, and on the cut surface, we have mostly necrosis area with like white to yellow tumor infiltrative here. And for the breast, from total mastectomy, this one. And she also have sentinel lymph node biopsy that's was negative for metastatic carcinoma. And for the serial section of the breast, we see kind of similar mass to the abdomen. It shows lobulated here, yellow to white, with necrosis area in the middle. When I fix the specimen for more than 10 hours and go back and come back to take a section, I have a tumor here like this, and it shows lobulated on the side here. And on central, it shows some necrosis area. For now, I still think about maybe this is a malignant phylloides with sarcomatous component like 2 years ago, maybe, or maybe something else. And I see this is lots of angiolymphatic invasion. So this is the vessel that's dilate after the tumor go through here, and it's called edema of the skin. And also here in the pectoralis muscle, we also see some like tiny nodule from angiolymphatic invasion. So this is what I see for the first attempt of my grossing. The tumor shows like chondroid matrix, lots of chondroid here. Yeah, when we took the whitish area that look lobulated here, we have lots of chondromyxoid matrix mixed with some tumor cells. The tumors show multinucleated giant cells, some epithelial and single cells, some blue round cells also receive like this. This looks so pleomorphic. But some area we see the blue round cell that look kind of aggregate and look epithelial-like area. And for this section, I think I see maybe it's trying to form lumen, maybe. And this cell look malignant. So I went back to lab and do what my senior breast consultation said 2 years ago. Okay, take it more. So I take some gross sampling for more, whether I have the malignant phylloides or something else. So I take around 10 more section. And in addition sampling, we have more area of this. This area, we see something that's similar to the last one, the sheet of epithelial cells, and maybe it try to form a lumen and mix with the sarcomatous component. And here, this to convince you guys, this is look kind of epithelial-like to me. And also it's time to poll. So let me start this. This is case 2. Okay, so can you see the poll? Okay, what? I leave you like 40 seconds or 50 seconds. Okay, so we enroll, and it seems more than a half, 66% you think about metaplastic carcinoma, and 10% for malignant phyllodes tumor, and 20% for primary sarcoma. Yeah, that's my differential diagnosis of this case. Okay, so let's see what going on after that. Come back to the area that's look epithelial, like here, and the area around here that's look chondroid. I put immunohistochemistry for epithelial membrane antigen or EMA is positive executively on epithelial-like area, but negative in chondroid-like area. And when I put S100, is positive in chondroid area, but negative in epithelial-like area. There's another area that's look like loose epithelial cells mixed with some blue round cells, and I throw immunohistochemistry on this. You may see focal positive for epithelial-like area in EMA positive, CK14 also positive, and CK56 focal positive, as well as P63 positive in some epithelial-like area. For S100, it negative on the epithelial-like area, CD34 is negative. So the final diagnosis is metaplastic carcinoma with heterologous mesenchymal differentiation, tumor grade 3, and mitotic counts more than 60% high power field. Tumor size is 10 centimeter, it's called like PT3. We doesn't see any DCAS area, and the resection margin are negative for tumor cells. And we see extensive angiolymphatic invasion. So the mass on at the patient abdomen could be metastatic tumor from this. And I put a comment like after I took extensive sampling, I have poorly differentiated carcinomatous area that's positive for EMA, CK, and P63 with S100 limit to only mixochondrial region. And we didn't see any leaf-like architecture that identify the malignant phyllodes, and CD34 also negative. So we can exclude malignant phyllodes tumor. And all of the findings are supported the diagnosis of metaplastic carcinoma with heterologous malignant mesenchymal differentiation. So for the top differential diagnosis of breast corneal biopsy with sarcomatous component maybe include the malignant phyllodes, metaplastic carcinoma, and primary sarcoma of the breast. So I've got, I will review a short review for each of the differential diagnosis. For phyllodes tumor, this is the biphasic tumor, and it shows epithelial and stromal component proliferation. And you can see in benign and borderline phyllodes, you may see the leaf-like fronds area like this. And for Western country, phyllodes is not common. So they said in some American literature, they said it's uncommon and less than 1% of breast tumor. But here, I think in Asian, in Thailand, we also have phyllodes tumor more than in Western country. And for the peak age, this range from 30 to 50 decade of life. And to differentiate from benign, borderline, and malignant phyllodes, we need some criteria for each. And for the pathophysiology and the cause of this is that most of the time is from DNA alteration. And also the copy number change, most common is for gain 1q and chromosome change, which see increasing in phylloides grade, the more grading is the more change of chromosome. And loss of heterozygosity LH, we see in high grade of phylloides tumor. And for the key mutation of phylloides tumor is MET12 exon 2. This present in both fibroadenoma and phylloides tumor. And for third promoter is seen in phylloides tumor more than in fibroadenoma. And for these abnormal, this mutation more common in borderline and malignant phylloides tumor. I think in Singapore, they also have a gene kit to evaluate phylloides tumor, but in Thailand, we still use morphology and also the criteria for WHO to identify the grading of phylloides tumor. And here, this is the table from WHO classification of breast tumor. The differential diagnosis of biphasic tumor is include fibroadenoma and phylloides tumor from benign, borderline, and malignant phylloides tumor. We need criteria for evaluate like tumor border, stroma cellularity, stroma atypia, mitotic, stroma overgrowth, and malignant heterologous element. And our case have complete all of the criteria. For malignant phylloides, the diagnosis criteria include marked stromal hypercellularity with marked nuclear atypia at the same time, and the presence of stromal overgrowth, mitotic, more than 10 out of 10 hyperfill, infiltrative tumor border. And if you see heterologous element like osteosarcoma, chondrosarcoma, this confirm malignancy, except for liposarcoma. In the new WHO, it said for liposarcoma, it doesn't count for the heterologous element. And important differential diagnosis is include metaplastic carcinoma and primary sarcoma of the breast. And for the metaplastic breast carcinoma, it's a heterogeneous group of invasive breast cancer with neoplastic epithelium. For the word metaplastic, that means the tumor can differentiate to squamous as well as mesenchymal-like component, chondroid, osteoid, and spindle cell. The metaplastic carcinoma is also rare tumor. It's less than 1% of invasive breast tumor. Normally, typically present in postmenopausal women and is the receptor negative, like triple negative. So for differential diagnosis of malignant phylloides tumor and metaplastic carcinoma, immunohistochemistry can be helpful. For CK panel, is negative in malignant phylloides and CD34 positive up to 75% of malignant phylloides tumor. And if you are in the situation like me, like have only spindle or malignant component on core biopsy, you can put the initial report like malignant spindle cell neoplasm and put a detail for histopathology finding, then recommend for surgical excision, like give me more of the sampling, we can evaluate more. Because the treatment of both tumor, they have a different from the other. For malignant phylloides, they don't need sentinel lymph node biopsy because the tumor have the hematogenous spreading more common. And for malignant phylloides tumor, it's uncertain role for adjuvant and chemotherapy. But for metaplastic carcinoma, the patient may benefit for adjuvant radiotherapy and neoadjuvant chemotherapy. And for primary sarcoma of the breast, to be honest, I've never have signed out or give diagnosis of this one. because it's extremely rare malignancy, less than. Oh, actually, I only sign out only angiosarcoma, but the other type of sarcoma I've never signed out on my experience because it's extremely rare malignancy, and typically it present as the rapidly growth mass with well-defined, and the size is big, like 5 to 6 centimeter, and most common in 5th to 6th decade of life. It's very rare in young women. For gold standard of diagnosis is histology examination with immunohistochemistry. And for the histologic subtype of primary breast sarcoma, most common are angiosarcoma that I mentioned before. I've been signed out for maybe 3 to 5 cases during these 10 years. And the other may be present, but most are case report like fibrosarcoma, leiomyosarcoma, osteosarcoma, liposarcoma, and chondrosarcoma. After I doing this topic, I try to find whether when the other diagnosis of primary chondrosarcoma of the breast, how they do, and how can they differentiate it from the other. And I found a case report from Italy. It was in 2022. It's a case report of primary extraskeletal myxoid chondrosarcoma of the breast. And look on the figure I put from the paper. They also show the chondromyxoid element like this, and they have FISH testing for EWSR1 rearranged that is positive in this case also. And for immunohistochemistry, they put lots of immunohistochemistry, and it's negative for cytokeratin P63, and for breast immuno like GATA3, mammoglobin, GCDFP15 also negative, and the immuno just positive for vimentin, S100, CD99, EGFR. So to differentiate diagnosis of three types of tumor, we have malignant phylloides, we have metaplastic carcinoma, and primary sarcoma of the breast. You can have this table for your differential diagnosis. For the component, malignant phylloides contain malignant stroma with benign epithelium component, while the metaplastic carcinoma, you may see carcinomatous component of epithelial component, and sarcomatous spindle, mesenchymal, and also squamous component. And in sarcoma, it's exclusively malignant mesenchymal tumor. And you will not see significant epithelial component. And for the architecture or key histology diagnosis, leaf-like architecture will appear in phylloides tumor. For metaplastic carcinoma, you may see spindle and squamous, and most of the time you will see necrosis and cystic change in metaplastic carcinoma. For high-grade sarcoma, you will see, like the other soft tissue tumor, you have the high-grade pleomorphism, sarcomatous component. And for immunohistochemistry, malignant phylloides stroma, negative for cytokeratin, and the epithelium component is positive for cytokeratin. For metaplastic carcinoma, the spindle and sarcomatous component is cytokeratin positive, like the case number 2. And for sarcoma, primary sarcoma is generally cytokeratin negative. All of 3 of these are triple negative for receptor status. So for the lesson learned of case 1 and case 2 is the core biopsy with limit of epithelial component. It can mimic malignant phylloides, metaplastic carcinoma, and also primary sarcoma. So the differential diagnosis of sarcomatous component of the breast biopsy may include malignant phylloides that you need for extensive sampling for epithelial component. And metaplastic carcinoma also need sampling for finding of carcinoma component. And for primary sarcoma, it's rare and need to exclude the previous two of this. Okay, so we just passed to case of metaplastic and malignant phylloides. So I come to the third case, number 3. This case, I think a month or 2 months ago. This one was a case of 75 years old female. She presented with the left breast mass for 6 months. She also have history of hypertension, dyslipidemia, and she and her family didn't have history of breast cancer. On physical examination, she have a left breast mass on 11 o'clock around 2 centimeters, and the physician does not palpable lymph node on axilla or supraclavicular. The imaging findings is called BIRAT4, and the size of the mass is 2 centimeters with well-defined and hypoechoic lesion. On cognitive biopsy, it's said, my resident, he said it's invasive carcinoma with cribriform architecture. And then she underwent for left breast wide excision with sentinel lymph node biopsy. And this is the gross finding of wide excision of the patient. This is the mass that look lobulated and kind of homogeneous white tan appearance around 2 centimeters. This is the histologic findings of this case. You see, similar to my resident, right? We have a big epithelial sheet around here with the lumen here. This look like cribriform pattern here. And also this one, the lumen and the cells around the lumen in this fashion. It seems we have something like secretion inside the lumen here. And the cells doesn't look so pleomorphic. And at the same time, the physician ordered immunohistochemistry for breast biomarker. For ER, seems a little bit positive here. For PR, maybe negative, doesn't see anything. For HER2, I think I have FENT around here. So on 400X, some membrane staining recognized, but just a few cells here. So still negative. And for key 67, this is around 15 to 20% positive for nuclei. And my senior resident, he asked for some immunohistochemistry. He asked for P63, CK56, and CD117 or c-KIT, and it appears like this. Okay, so it's time for vote. What do you think about this one? Let me launch the vote. Okay. Okay, so it seems, let's see the result. So 60% of you said it's adenoid cystic carcinoma, and around 20 have a differential diagnosis between DCIS or cribriform pattern and cribriform carcinoma. Okay. Okay, let's move on. The final diagnosis of this one. So for the final diagnosis of this case is adenoid cystic carcinoma, and it is a classic type of adenoid cystic carcinoma. The tumor size is 2 centimeter, and when I go through Nottingham's grading, it's grade 2, and also present DCIS grade 2. Close to the main mass. The resection margins are negative for tumor, for invasive tumor, and for DCIS. And the pathologic staging is T2 without lymph node or metastatic negative. So it's just P2N0, M0. For breast biomarker, I have ER low positive, like 1 or 2% intensity of 1 plus. For PR is negative. And for HER2 score, I give it to score 0 with the pattern of weak incomplete membrane staining less than 10% of tumor cell, as I showed you before. And for key 67 is around 15 to 20%. So I will review a little bit about adenoid cystic carcinoma because this one is triple negative but have some feature that's interesting. Adenoid cystic carcinoma is an invasive carcinoma that composed of luminal and myoepithelial component, and it's quite rare, less than 5% of all tumor of breast cancer. And it has two subtype. One is classic adenoid cystic carcinoma that have two well-defined cell population, usually not more than grade 1 or grade 2, and 70% to 90% have MIP gene rearrangement. The other type is solid basaloid adenoid cystic carcinoma. This consists of myoepithelium, and the tumor grade, nuclear grade, frequently is in the high grade, like grade 3, and only 10 to 20% is positive for MIP gene rearrangement, and around 30% have notch mutation also. The important about the subtype of adenoid cystic is the classic adenoid cystic carcinoma. Even it's triple negative, but it had excellent prognosis. 100%, almost 100% of patients survive at 10 years after diagnosis, and it can be successfully treated with local therapy. So if we call it classic adenoid cystic carcinoma, the patient, maybe she doesn't need chemotherapy on this one. But if I call it solid basaloid adenoid cystic carcinoma, this had higher likelihood to distant metastasis and maybe treat with chemotherapy. So the problem is sometimes we overdiagnose of adenoid cystic carcinoma that should be avoided because 20% of adenoid cystic carcinoma on review does not fulfill the criteria of classic adenoid cystic carcinoma. So let's review a little bit about the criteria and the findings of classic adenoid cystic carcinoma. The architecture pattern for classic, most of the time it show like this, the cribriform pattern. We see the lumina in low power, and sometimes you may see reticular or tubular architecture. The tumor cell like reticular pattern and have abundant stroma around here. And for less than half of the architecture, you may see solid component, but the cytology feature is show a small cells and scant cytoplasm like this. And you don't see marked pleomorphism or increased mitosis. And occasionally, you may see squamous or sebaceous differentiation. In contrast, for the subtype of solid basaloid adenoid cystic carcinoma, the architecture shows, like its name, the solid pattern. You may see the solid sheet on low power, and the cribriform pattern is not common here, and the basement membrane-like material does not see here. The nuclear grade, look on the right side, is bigger and is higher nuclear grade in solid basaloid adenoid cystic carcinoma. And on low power, you see the invasion, like this rack nest rather than circumscribed border. And for immunohistochemistry, the luminal cell of adenoid cystic carcinoma show positive for cytokeratin. And the cell on this side, this is my epithelial cell. This positive for P63, calpanin, CK14. And for hormonal receptor, it's almost all of adenoid cystic carcinoma triple negative, that's ERPR predominantly negative, and HER2 mostly negative in both subtype, and androgen receptor positive in some tumor. And for MIP expression, adenoid cystic carcinoma is like adenoid cystic carcinoma from the salivary or the other sides. It shows MIP positive in 90% of classic adenoid cystic carcinoma and solid basaloid adenoid cystic carcinoma. So you can run the genetic test in the case that's challenging, because absence of MIP gene does not truly exclude adenoid cystic carcinoma. So if we have the complete classic morphology, we can go through the diagnosis without do genetic testing. The genetic testing should be done in the challenge case or in high grade or the case that look like a variant of adenoid cystic carcinoma. So this is the other case report from Human Pathology 2014. So this is the classic adenoid cystic carcinoma, and they also do MIP gene rearrangement and immunohistochemistry. So the differential diagnosis of adenoid cystic carcinoma could be include the tumor with triple negative and basaloid feature. Some cribriform carcinoma and DCS may be included in the differential diagnosis. Solid papillary carcinoma, sometimes it shows cribriform pattern that may make you think about the differential diagnosis in the adenoid cystic carcinoma. Collagenous spherulosis, on low power, you see like cribriform pattern, but it's all benign, like adenomyoepithelioma. So the lesson learned from case number 3 is cribriform pattern with triple negative for hormonal. Please think about adenoid cystic carcinoma. And then we have to identify the population luminal cells that's positive for CD117 and the myoepithelial that's positive for P63. The classic adenoid cystic carcinoma is indolent, so surgery alone may be sufficient for the patient in this group, while solid basaloid adenoid cystic carcinoma is high grade and need chemotherapy after that. So please avoid over treatment of this group. So this is come to the end of our 3 cases. The takeaway message from this case is case 1 and case 2. We try to differentiate between malignant phylloides and metaplastic carcinoma. So sometimes if we have the situation like that, immunohistochemistry alone does not enough. We need extensive sampling for finding the epithelial or something else. And for case 3, the takeaway message for you guys is triple negative doesn't mean poor prognosis. because we also have classic adenoid cystic carcinoma that is even is triple negative, but the prognosis is good. And to integrate between morphology, immunohistochemistry, and molecular, ensure the accurate classification and appropriate management for the patient. And as pathologists, we serve as a bridge to connect tissue morphology to therapeutic precision. And this is the reference of my talk, and this is the finish of my talk. Okay.
So, thank you very much, Professor, for your excellent presentations. We have received several interesting questions from the audience, and now we will move to the Q&A sections. And thank you to everyone who has submitted their questions. And please feel free to continue adding your questions in the Q&A box. And the first
Yes.
question is, Professor, they want to know the prognosis of the tumors, especially the metaplastic carcinoma and phylloides tumors, according to your experiences. What is the prognosis for these tumors?
The prognosis of
Yes,
metaplastic?
yes, metaplastic carcinomas and the
Oh,
phylloides tumors. Yes, according
for
to your,
metaplastic,
yes,
the first case,
yes,
that is the malignant phylloides. Do you remember that?
yes.
After we took the breast mass out, she then lived for 3 years. She just
Oh,
she just passed away this year. And if
oh,
for malignant phylloides, if we have removed all of them, maybe almost 5 years can be possible. But for metaplastic carcinoma, I think if they have chemotherapy, and
mhm.
also even if have the poorer prognosis than the other, but chemotherapy can be helpful. If we compare to the other breast cancer, is have poorer prognosis, but if you diagnosis earlier, this can be helped.
Oh, yes, Professor. So maybe we should let's move to the second questions. So uh, the pathologists want to know what would you recommend as the minimal IC panel for these kind of spindle cell tumors to differentiate between benign or malignant like this?
Minimal IC panel
Yes,
for
yes,
spindle cell. Actually, the key message for the first and second case is take it more for histology finding. The immunohistochemistry that can be helpful is CK, maybe. If you have some area, you just think about metaplastic, and maybe P63, CD34, but this immunohistochemistry will be helpful if you have the target of histology. So the key message, you have to find out the component of epithelial or the sarcomatous component. So to me, I prefer do ISC on the excision biopsy rather than the core biopsy that may not present the epithelial component.
yes, Professor. And uh, let's move to the next questions. This next question is about the adenoid cystic carcinoma, and he is wondering, is the Nottingham grading system applicable to adenoid cystic carcinoma of the breast or not?
Oh, yes. Yes. Also use the Nottingham grading. We still use the Nottingham grading on adenoid cystic.
Yes, Professor. Thank you so much. So, and the other one, the other pathologist is wondering, he just want to make sure in the second case is the right abdominal mass is a metastasis from the metaplastic carcinoma of the breast. Is this correct, Professor?
Yes, we
Yes,
think the morphology looks similar to the
yes,
breast.
Professor. Yes,
And actually, I ran some immunohistochemistry and it looks similar. So we
Oh,
think about metastatic from breast to abdominal, but it's rare. I mean, I see some case report is talk about metastatic of breast to abdomen, but
yes,
less than 10.
yes, Professor. Thank you for these very rare cases presenting today and letting us know today. And the other one, the other pathologist is just wondering, could you just explain about the origin of the metaplastic carcinoma, primary breast cancers, and malignant phalloides tumor for maybe topic is last for
Wow.
today. Yes, maybe I'm think maybe just a
Maybe.
short one.
Wow.
Yes,
Just
maybe it is.
wonder.
Mm,
Maybe I can find later. But the
yes,
for metaplastic carcinoma, as its name, I
yes,
mean, is metaplastic. That's name come from the change from one type to the other type. So mostly the breast cancer is glandular. So when it show metaplastic, it turn from glandular to mesenchymal or even squamous. That's why it's called metaplastic carcinoma. But the origin is also the glandular, like the other breast cancer. And for malignant primary breast cancer, and for malignant phylloides, its origin is we believe is also biphasic tumor with alteration of molecular, like I mentioned in my lecture.
yes, Professor. Thank you so much. And the next question is the role of the PD-L1 IC in triple-negative breast cancers and their roles in immunotherapy for malignant breast tumors. And if we have to do the PD-L1 IC in malignant breast tumor, which clone would you recommend in the management of malignant breast tumors?
Wow, maybe this out of my expertise, because PD-L1 for breast cancer, uh, I think we have a few cases, and sorry, I've sent out for consultation,
It's okay,
not
Professor.
in
Yes,
my expertise.
yes,
So,
yes, Professor.
but maybe I can find you later on.
Yes, of course. Anyway,
Mhm.
thank you so much for your answer, Professor. And the next question is, do you find the next generation sequencing and genetic testing is helpful in daily practice in these kinds of ambiguous spindle cells lesions? Do you
Hmm.
find the genetic testing or genetic test?
Oh, actually, for NGS, helpful in spindle cell lesion.
Yes.
For the breast spindle
Yes.
cell lesion,
Yes,
we
spindle
never
cell
we
lesions of the
we never
breast.
send for NGS because most
Yes.
of the time we can make diagnosis by histology and immunohistochemistry. But I'm sure for the soft tissue tumor, they
Yes,
use NGS for spindle cell lesion.
exactly, Professor.
Yeah.
Thank you so much. Yeah. So, so let's move to the next questions. Um, in
Mhm.
the in the presentation, Professor, you have mentioned that uh, you should submit as much as the sampling as required to support the diagnosis. Would you recommend which area we should emphasize? Is there anything we should emphasize in the submitting gross samples?
Oh, for submitting gross sample, you mean in
Yes,
the spindle cell?
yes, for these kinds
Oh,
of tumors, which areas we should emphasize to take before taking or submitting the
okay.
samples? Yes,
Firstly, try to submit the viable area. For necrosis, maybe it doesn't help because you don't have the viable tumor and the morphology is kind of difficult. So take the viable and look for if we have differential diagnosis of phylloides tumor, take the area that's look leaf-like, something look cleft,
yes, yes.
look like a solid component. That will
Mm,
be helpful. But for metaplastic carcinoma, I recommend first sampling the viable area. Second, try sampling the area that on close to the main mass. because at this area, we may see in situ lesion. If
Yes.
you have DCIS with
Mhm.
the metaplastic carcinoma, this going to be helpful and is a clue for, okay, we are dealing with breast carcinoma, not the sarcoma.
Yes. Thank you, Professor. And so let's move to the next question. Um, how do you see the roles of the genetic testing in the families members of the patients? Uh, when should we consider genetic testing for the breast cancer patients and also for the families?
Oh, for family testing, this is a
Yes,
big issue in Thailand
yes, yes,
because lately, I think 2 years ago, the government started policy that we allow to some women to, if they have a risk, they can go through BRCA mutation testing. So
yes,
I think this going to be more and more in the policy. And in my hospital, they're going to start the test this year as well. So I think
yeah.
that the genetic testing going to be the next wave of the testing in this region. So can I ask back, what about in Myanmar? Do you have the
Ac-
genetic testing?
Actually, we do not have the precise guideline for testing the BRCA1
Mm-hmm.
as much as I know currently.
Mm. Yeah. So I think if we have started, we can help lots of patients at the young, maybe.
Yes, yes, Professor. Thank you for sharing. And the next question is, we know that the collaboration between the clinicians and pathologists is very important in treating the patients. What are the key messages you would like to convey to the clinicians when you encounter with these kinds of rare spindle cells or cribriform breast tumors? And how do
Mhm.
you think, how can we strengthen the collaboration between the teams of molecular pathology, clinical oncology teams to optimize the patient selection for targeted therapy? How
Oh,
can
okay.
we
How
strengthen
can?
this? Yeah.
Because the nature of pathologists, I don't
Yes,
know if you are similar to
yes,
us.
yes,
We kind of introvert person.
yes, yes,
We don't
sure.
love to see
Yes,
people. We don't love
yes,
to like talk to patient, but
yes,
we good on writing, right?
yes, right.
For our communication.
Yes,
So as our nature like this is kind of difficult to
yes,
talk to the other. So I think the meeting, like multidisciplinary meeting,
hmm,
should be good on
yes,
on consultation. In my hospital, we have breast cancer planning meeting every weeks. So the clinician, they just said, okay, we going to do this case, and what do you think about this one? So if we have the meeting like this, we can share the experience, and sometimes I can ask them like, okay, can you go for more, and can you have something else? I don't think about this and that. That is a good for start the communication, because in normal, I don't think I don't think we want to call any other outside the department, right?
yes,
Because
yes,
I just say, oh, leave me alone, and anything you want, just tell me. So
yes,
if you arrange the multidisciplinary meeting, that's one of the best way to convey the communication.
yes. Thank you so much, Professor. I also think that that is the best way because for me, I'm also a bit hesitant to communicate with a
Mm.
lot of people. Naturally, like this. So thank you, and let's move to the next question. That is, how do you see the role of digital pathology or
Mm.
teleconsultation in handling rare cases or
Mm.
complex breast pathology cases like these ones?
Mm. The role of digital pathology and
Yes,
teleconsultation.
yes,
Wow. Actually, for the development of whole slide imaging, like slide scanning, I think it's come like 3 or 5 years earlier. And lots of labs in Thailand also start to develop this system for
yes,
telepathology and consultation. So I agree with this one. And actually, I have a small study in my hospital to compare the validity of the scan between like microscope and the scan. And what do you think about the result? Let's guess.
Maybe I don't know. How should I guess? But I think this will be a great result, don't you think?
Yeah,
Yes.
almost perfect. I mean,
Oh,
the between the slide scanning and light microscope is comparable. I mean, you can use slide scan uh, as well as microscopy, but uh, we need to train about the how to read the scan slide.
yes,
And from my paper and the resident, I compare the time for evaluate
yes,
by slide scanner.
yeah.
And can you guess who is faster on slide scanner between me and the resident?
The resident?
Yes.
Yes,
So
because maybe the resident is more familiar with uh, uh, the technology, maybe
yeah,
like that. Yes.
yeah. And sometimes I'm kind of paranoid of where is the mitosis, can we see it? But actually it's still we can see it on slide scan like the microscope. But for the previous generation like me, I have to adjust a little bit, and maybe we get better if
Ah,
we use
did
it
not think.
every day.
Yes, thank you, Professor. Maybe you are not the next in the previous generations at all. Professor, in using the digital pathology, you need to validate with the resident first, right?
Actually, in from CAP
Yes,
recommendation,
yes,
they said if you want to develop digital pathology in your institute, you have
yes,
to validate it with pathologists and
yes,
resident or whoever use
yes,
the system. We need at least 60 slide
yes, Professor.
scan, and you need like the concordance rate around 80 to 90%. And if it's not matched, you have to find out what happened. So for digital pathology, I think we can use it on H&E slide, but for cytology, I still wonder because we need the C stack, like the cells sometimes it's so thick, so it's difficult to evaluate by scan slide.
Yes, Professor. So we have got some questions for the HER2 testing.
Mhm.
Uh, uh, how do you think about using the HER2 testing in using the AI tools?
Wow, does it come from the company or someone?
Yes,
So um, I think 2 years ago, the company, the slide scan company also include the AI application for HER2 evaluation. I have read some paper and it said the HER2 scoring in digital scan and AI is pretty uh, similar, maybe better than just your eye. But I've never tried this one. So
yes.
for what about nHelp? Have you ever tried
No,
HER2 app?
no, not in and help Myanmar. We haven't tried that.
So maybe we can next
Yes,
next
maybe.
year.
Yes,
Mhm.
yes, yes. Actually, Professor. And this is the last questions for today. And how do you think the rules of HER2 testing in the metastatic breast tumor or recurrent breast cancer cases?
Uh-huh.
Mm. Do you
Mm.
notice any HER2 status changes between the primary and metastatic tumor?
Actually, in most of the study, they said HER2 mostly they doesn't change, but after metastatic, but sometimes we see change in the status in the metastatic also. For my institute, we recommend retest HER2 in all recurrent and metastatic tumor.
Ah, Yes, Professor. So maybe we have time for one more questions. Uh, this is how do you handle cases with equivocal ISH results? That is between the around the
Mhm.
borders like 1.8 to 2.2 or borderline amplifications. How do you handle these cases?
Oh, actually, in my institute, we just start in situ hybridization for 6 months.
Yes.
Before that, we send it out to the outside lab. And for equivocal result, firstly, we have the second pathologist to read it again. But if it's still equivocal, maybe we choose the other block or choose the other platform to do in situ hybridization again.
Ah, yes, Professor. So So maybe we should close for the today's sections. Professor,
Okay.
thank you so much for addressing these insightful questions and thank you for sharing your valuable insights and expertise with us today. And we would also like to extend our sincere thanks to all the participants who joined us today, asked questions, and actively engaged during the sections. Your participation makes the discussion even more meaningful. And for any question that we cannot touch today, we will submit to the professor and we'll get back to you by email. Now, I
Okay.
will hand over to Dr. May for a few final words. Thank you, Professor, and all.
Thank you.
Thank you, Dr. Su, and thank you again, Professor Wanwisa, for sharing your expertise with us today. And we also like to give a special thanks to Roche for providing the venue and Dr. Kritika from nmmpathology for invaluable support in organizing the webinar. To all participants, and thank you for joining us. Please take a moment to fill out our short feedback form, and don't forget that nHealth Myanmar offers the Visit H&E service, the digital scanning service, IHC, and second opinion consultation service. And thank you again. We look forward to seeing you at our next section. Have a nice day. Bye bye.